Welcome to Medicine Made Easy, your go-to destination for simplified medical knowledge and insightful discussions. Today, let's focus on hyperthyroidism in pregnancy. Is hyperthyroidism something you need to worry about during pregnancy? What are the symptoms? How can it affect baby? And most importantly, what are the treatment options? In this video, we'll delve deep into the world of hyperthyroidism in pregnancy, answering all your burning questions and providing valuable information. Physiology of maternal and fetal thyroid function, HCG and TSH receptors. With the onset of pregnancy, HCG levels rise, peaking at 8 to 11 weeks, stimulating maternal TSH receptors and increasing thyroxine concentrations. Thyroid binding globulin, TBG. Under the influence of maternal estrogen, TBG synthesis increases, leading to higher binding of total thyroxine and a mild decrease in free thyroxine levels. Placental deiodinases. Deiodinases in the placenta regulate the conversion of thyroid hormones, ensuring adequate intraplacental T3 for fetal development and protecting the fetus from excess maternal hormones. Placental deiodinase 2 converts T4 to T3, while placental deiodinase 3 converts T4 to reverse T3. Classification of hyperthyroidism in pregnancy. Classified as overt hyperthyroidism, subclinical hyperthyroidism, overt hyperthyroidism. Characterized by suppressed TSH and high total or free T3/T4, overt hyperthyroidism is a more pronounced form of the condition requiring immediate attention. Subclinical hyperthyroidism. Subclinical hyperthyroidism presents with suppressed TSH but normal total or free T3 and T4 levels, making it a less obvious condition to diagnose. Hyperthyroidism versus thyrotoxicosis. Hyperthyroidism. Hyperthyroidism is due to excess production of thyroid hormones by the thyroid gland. In thyroiditis, thyrotoxicosis can occur from the destruction of thyroid follicles, releasing hormones into the bloodstream. Exogenous sources. Excess thyroid hormones can also be introduced externally through overtreatment or factitious disorders. Causes of hyperthyroidism. TSH receptor stimulation. Excess stimulation of TSH receptors can lead to increased production of thyroid hormones. Graves' disease. This condition is characterized by TSH receptor autoantibodies leading to hyperthyroidism. Gestational transient thyrotoxicosis. Occurs due to HCG induction during pregnancy, causing temporary hyperthyroidism. Trophoblastic disease. Another HCG-induced condition where abnormal cells grow inside the uterus after conception. TSH-producing pituitary adenoma. Autonomous production. Autonomous thyroid hormone production occurs independently of TSH receptor stimulation. Autonomous thyroid hormone secretion. Multinodular toxic goiter. Solitary toxic thyroid adenoma. Activating TSH receptor mutation is a genetic mutation causing the TSH receptors to be overly active, leading to hyperthyroidism. Extrathyroidal sources. Thyroid hormones can also originate from sources outside the thyroid gland, contributing to hyperthyroidism. Struma ovari. A rare ovarian tumor that can produce thyroid hormones, contributing to hyperthyroidism. Functional thyroid cancer metastases. Metastatic thyroid cancer that continues to produce thyroid hormones outside the thyroid gland. Consequences of uncontrolled hyperthyroidism include spontaneous abortions, premature delivery, low birth weight, fetal programming, and hyperthyroidism. ADHD link. Studies suggest a possible association between maternal hyperthyroidism and the development of ADHD in children. Epilepsy concern. Research indicates a potential link between maternal hyperthyroidism and epilepsy in offspring. Thyroid function tests and pregnancy. Total T3/T4 values in pregnancy are 1.5 times the non-pregnancy reference range. Overt hyperthyroidism is indicated by a TSH level below 0.1 μ/L, high total or free T3/T4 for the pregnancy-specific reference range. This snippet shows the normal levels of thyroid hormones for each trimester. We will discuss in detail about the most common causes for hyperthyroidism in pregnancy. 1. Gestational transient hyperthyroidism. 2. Graves' disease in pregnancy. It is vital to distinguish between gestational transient hyperthyroidism and Graves' disease for proper treatment. Comparison between the two common causes of hyperthyroidism. We will discuss about the differences in following side headings. In gestational transient hyperthyroidism, hyperthyroidism occurs during first trimester. Graves' disease occurs during any time. And gestational transient hyperthyroidism symptoms and signs are absent before pregnancy, while in Graves' disease symptoms might have been present prior to pregnancy. Gestational transient hyperthyroidism usually mild. Graves' disease any grade of severity. TSH receptors antibodies are present in 97% cases of Graves' disease. Gestational transient hyperthyroidism is self-limited. Graves' disease unpredictable course. Approach to hyperthyroidism in pregnancy. First investigation we usually order is thyroid profile. Look for height-free T4 and suppressed TSH levels. If any symptoms of goiter, ophthalmopathy, or prior history of thyroid disease, TRAB positivity. If all of these are present, diagnosis is Graves' disease. If there is history of weight loss, nausea, vomitings, TRB negative, go for ultrasound abdomen. If there is any vesicular mole, go for surgery. If ultrasound is normal, it is gestational transient hyperthyroidism in pregnancy. It only requires symptomatic treatment. Thyrotropin receptor antibodies are increased, diagnosis is probably Graves' disease. If TRAB antibodies are normal, IT can be gestational transient thyrotoxicosis. If antibodies are negative, go for ultrasound of thyroid gland to assess thyroid blood flow. If blood flow is low, thyroiditis is likely. If blood flow is increased, goiter is mostly likely. Let's dive deep into the treatment of gestational transient hyperthyroidism. Gestational transient hyperthyroidism. Usually, the condition is self-limited and antithyroid drugs are not usually required. Supportive treatment. Low-dose beta blocker, propranolol, may be given in case of severe symptoms. Antithyroid drugs are usually not recommended as thyroid function returns to normal by 14 to 18. Management of Graves' disease in pregnancy. The aim of treatment is to maintain total T4 and free T4 in the high normal reference range for pregnancy. Preferred ATD therapy. Drug of choice varies based on trimester. Methimazole. Initial dose, 5 to 30 mg per day. Usual dose is 10 to 20 mg per day. Carbimazole. Initial dose is 10 to 40 mg per day. Usual dose is 10 to 30 mg per day. PTU dose is 100 to 600 mg per day. Usual dose is 200 to 400 mg per day. The initial dose of ATD is based on the severity of hyperthyroidism and symptoms. The equivalent potency of MMI to PTU is approximately 120. MMI can generally be given as a single daily dose, while PTU dosing should be split into 2 to 3 daily doses due to its shorter half-life. Preferred treatment options. Early gestation. It is reasonable to use PTU as the preferred option in women with hyperthyroidism in early gestation. First trimester switch. Patients on MMI/CMZ should be switched to PTU if pregnancy is confirmed in the first trimester. Post-first trimester. After the first trimester, switching to MMI/CMZ may be considered in view of the risk of hepatotoxicity with PTU. Specific drug concerns. Carbimazole. Aplasia cutis. Choanal atresia. Patent vitellointestinal duct. Esophageal fistula, omphaloceal, imperforate anus, microcolon, gallbladder aplasia, ventricular septal defects, hypoplastic nipples, developmental delay and coloboma of the iris or retina. Propranolol. Potential side effects like bradycardia, hypoglycemia, preterm birth, and small for gestational age. PTU. Fulminant hepatic failure in the mother. Birth defects of the face and the genitourinary system. Monitoring and adjusting treatment. Monitoring frequency for. In women being treated with antithyroid drugs in pregnancy, free T4 and TSH should be monitored every 2 to 4 weeks. Treatment goal is to maintain free T4 at a high normal reference range. Medication withholding. In a woman diagnosed with Graves' disease and on anti-thyroid disease, when found to be pregnant, may opt to withhold medications if clinical and biochemical features are suggestive of remission. Antithyroid drugs and fetal impact. All antithyroid drugs can cross the placental barrier, affecting fetal thyroid function. Treatment aim. The goal is to maintain maternal thyroid hormone levels in the high normal range to prevent fetal hypothyroidism and goiter. Minimum effective doses. The smallest possible dose of antithyroid drugs is used to achieve the treatment aim and reduce fetal risks. Thank you for watching. Upcoming topic is on hypothyroidism in pregnancy. Please like, share, and subscribe for more such interesting lectures.